Hey, everybody, welcome back to another episode of Confessions of a Male Gynecologist. I'm Dr. Shawn Tassone, your esteemed host, doing what I love, talking to you about women's health and hormones, author of the Hormone Balance Bible with HarperCollins that you can get on Amazon for about $16, 500 pages of everything you ever wanted to know about women's hormones and how to treat disorders and hormone imbalances. I got the 12 most common imbalances. You can also find me on thehormoneproject.com. It's a monthly membership website that I have for those women that want to go deeper into their hormonal journey, figure out more, learn more about dosing, learn more about different types of hormones, how to take them. Thehormoneproject.com. You can stay in as long as you want. You can leave whenever you want. It's not a prison. It's an educational thing. I was listening to some podcasts over the weekend, and I kind of stumbled upon a podcast about what I feel is the downfall of the medical education system and kind of why women I feel like might be getting gaslighted all the time by my colleagues and my providers. And this has to start somewhere. It just doesn't start out of a void. And so if we look at medical education and what is the state of medical education right now, and my concern is that medical education is screwed. Applications are down. The competition pool is down. I'm not saying this as one of those old guys that's all about, well, back when I was in the WWII, I'm not that guy, but and I'm sure every generation feels like they worked harder than the one before, but I will tell you there is something to this because I started medical school in 1990. And when you are in medical school, and the first 2 years are usually classroom stuff. And then in the second 2 years, you do your clinical rotations at the hospital. And you do, psych and pediatrics, surgery, OB, pediatrics, and you go through all these rotations, and that's when you try to figure out what you want to do with your life and what hits you as being this lifelong dream of yours. So, the first 2 years are pretty easy because you just sit in a classroom and you take notes and you take tests. I mean, I don't mean easy in the sense that I didn't fail a test or two. I mean, easy in the sense that you just know what you do. You're ascribed this thing. And nowadays, because my son, who is a fourth year medical student right now, had it a little bit different because it was during COVID. And naturally, a lot of things went to online. But before we went to COVID, I went through COVID. I live in Austin, and so Dell Medical Center's here. And a lot of the students' classes were online. And I don't know. I don't think there's necessarily a difference for classroom stuff as to online or in person. And I do think they've been trying to change the way that the students learn. And instead of making them wait until they go into the third and fourth years, they start trying to introduce them to more clinical things earlier on, which I think is a great model. The problem that I have, the reality that we see is that there are doctors that are coming out of residencies, not medical schools so much, but residencies, and they have no idea what they're doing. And that's because the medical education system sucks. And it's kind of because, in my opinion, it got a little bit overzealous, meaning it worked, the model worked for decades, for centuries. And because of certain probably political pressures, it became more prevalent that there needed to be more education. So they started introducing decades ago that students had to learn about geriatric medicine. That was something and the problem is, though, is if you keep adding things in, then the brain power can only take so much. And when you keep adding in different topics, like let's say we brought in geriatrics, well, then something else has to get cut because you can't learn everything and you run out of time. So what happens is, as some of these newer topics would come in, then we would have to de-learn or not learn other things, which I think unfortunately is wrong, because the tenets are the same. You want to learn about surgical stuff, you want to learn emergency stuff, you got to learn those things if you're going to be any good at anything. So you have these medical students that maybe are not necessarily choosing things that they feel like they should really go into. So it's March 2025, and my son is putting in what's called his match list. He's decided to go into anesthesia. In order to get into a good program, there's 2 tests that you take as a medical student. It's called the USMLE, the United States Medical Licensing Examination, I believe is what it stands for. So you take step 1 after your first year, and I think, or your second year, and you take step 2 after your third year. Now, back when I was taking these tests 900 years ago, you had to get a certain score. We had to score 70 or higher on this test to pass. And if you didn't do it, you'd have to repeat second year. It was horrible. So much stress. So you study for the summer, and you take this test to decide if you're going to move on. Luckily, I moved on. But now they don't do those percentages anymore. It's simply a pass fail. And the passing rate is the 5th percentile. So you have to get a 5% or higher on the USMLE to pass it. I mean, that literally means if there were 100 questions, you only have to answer 5 of them right. So we're already dumbing down the passing process, right? We've taken the rate from 70 to 5%, which means you could be a complete moron and maybe guess 5 answers correctly, especially if it's multiple choice. I don't know if I want that person taking care of me. Now, there was always a joke in medical school that, what do you call the person who graduates last in their medical school class? Doctor. And then the joke would be, and someone's seeing that person tomorrow. Now, not just because you graduate last doesn't mean you're a bad doctor. I mean, I'd rather be last in my medical school class than last in, accounting class, because you're still going to be a doctor and you still know a lot of things. But where you learn all the meat and potatoes is in residency. And that's what a lot of these other professions, they don't talk about, like chiropractics and naturopaths and things like that. They say, oh, we have the same training as doctors. Well, no, you don't, because we do a residency for another 4 to 5 years that y'all don't do. So we clock in a lot more hours. And the truth is, in medical school, when you're doing those hospital rotations, you're pretty protected, meaning you can't really get overworked. So here's a great example. I was the chief resident in high-risk OBGYN. This would have been in 97. And I think I had 3 residents underneath me. So we had a third year, a second year, and a first year. And they all would, when you're the chief, you kind of supervise. So you let the lower level residents run the show. And then the medical students were kind of used as filler, like go in the room and ask the patient, what she's feeling and stuff like that. So I remember one day, it was I believe it was Friday, and I said to the students, I said, hey, I know Monday's a holiday, so why don't we just have, I think there were 6 students. I said, why don't you guys divvy up the weekend? So like 2 of you do rounding Saturday, 2 do Sunday, and 2 do Monday. And they said, well, we're not working Monday, it's a holiday. And I said, well, the patients aren't going home and we're going to be here, so y'all need to be here. And I didn't think that was being too harsh. I mean, you're in medical school, you should want to do medical stuff. And hey, guess what? Life doesn't always have a freaking vacation. So anyways, they kind of pissed and moaned a little bit. And then about an hour later, I got a call from the dean's office. And they said, you can't make those students work on Monday. So somebody went to the dean to complain that they had to work on Monday. So here's the thing. I said to the dean, does that mean I don't have to work on Monday? And they said, no, you have to, because we're paying you, which they were. As a resident, you get paid, but the medical students aren't getting paid. And I said, well, what are we teaching them if we're teaching them that if somebody's sick on Monday, Memorial Day, they don't have to go see them. Well, there's going to be somebody on call. And that was my point, was for them to come up with a plan where the 6 of them would sit down, just like we have to do when we're like now. One of the other OBs in town will call me and say, hey, do you have any days off that you want in April? I'm making the call schedule. Somebody has to be available. You can't just say it's a holiday. So these people are going to get out and think that they've got, that they don't have to work and that they're not responsible for anything, which is obviously totally ridiculous. So that was my first initiation into this aspect that maybe the younger generations were going to be different. The Gen, Zs and the millennials and things like that. The problem is that you can't teach a work ethic. That's just something that you're born with. And personally, I would rather have somebody standing next to me in the medical field that is a workaholic, in the sense that they do a good job, they are determined, they are pushed, they like to push, and you know what you're going to get from them. I don't want this person next to me that is going to be asking for Monday off because of whatever. And I know that sounds harsh, but at the same time, we're all in those trenches, all the residents, all the medical students, we're doing all the work, and we have to all be on the same team. So here's the thing. You take this USMLE test that I talked about and you pass it, and then my son puts in his match list this month. So he ranks his top 7 to 10 programs. He wants to go here, he wants to go here in the order that he wants. And then all the programs will rank the doctors, the upcoming residents. And then on March 21st, I think this year, they find out where they're going. It's kind of an exciting day. But there's always going to be some kids that don't match because it's competitive. And they have to figure out what they're going to do, which is always a fear for all of them. I remember feeling that way as well. And I can still remember my rank list. I think I ranked the University of Oklahoma first, and then I want to say the Medical University of South Carolina second, Ohio State third. I think I put Vanderbilt fourth. University of Kentucky, I think, was up there. But I got the University of Oklahoma because they liked me. I did, when I interviewed there, it was a really good interview. And so anyways, to make a long story short, you then get into your residency program. Now, we have a lot of studies, especially in surgeons, that show that they're not getting the training that they need. So let's just say I did my residency at the University of Oklahoma. From day one, we were doing stuff. I delivered, I can't tell you how many babies on my first day of call. I think I did a C-section. I'd never done a C-section before. But because of the volume being so high, you were just kind of thrown into the deep end of the pool. No floaties, no nothing. And guess what? You freaking learned how to swim really fast. And you got better at it over time. I remember we used to be afraid to call our chief resident because we didn't want to be humiliated. They made us learn on our own. And good or bad, it makes you scrappy. It makes you a better diagnostician. It shows you that that you can handle hot situations, that nobody's going to die on your watch, that you've got things under control. And I'm really appreciative for that, because I had a colleague when I lived in Tucson who went to Harvard. And I graduated from residency. I'd probably done 75 hysterectomies myself when I got out of residency. She had done 5. So she was really smart. She went to Harvard, did her residency at Harvard, but she couldn't operate her way out of a paper bag. And I'm sorry, but when all these people are always talking about, oh, Harvard this, Harvard that, that doesn't mean shit to me. What means something to me is, how good are you at what you're doing? And so that's something that I really held on to. And I think that means a lot. And what we're seeing is there are people coming out of residency that don't have the chops. They can't operate. They don't know what to do. They technically, when you graduate from your residency program and you go into private practice, you are able to practice medicine, and you should know what to do. Now, that's not to say you're going to just cure diseases and you're going to be the best thing since sliced bread, because I can tell you, my attending said to me that I didn't know how to sew worth shit. And I think it's because I'd never done it before. But the berating was like, and I know it's a different time, but the berating kind of pushed me to want to do better. And if you think about the word resident, why do we call physicians that are learning in the hospital residents? That's because the generation before mine, they actually lived in the hospital. Like when you would get your residency, you lived in the hospital, you got room and board, and your apartment, if you will, was in the actual hospital. You lived there. So that's why I'm saying my generation, probably the guys before us, probably thought we were weak because we weren't living in the hospital anymore. We'd moved out into the, apartments and whatnot. My generation looks down at the next generation as being kind of lazy, participation trophies, the whole 9 yards. The reality is this, though. We're putting out doctors that are less trained because we've dumbed down the admission process, we've dumbed down the testing process, and then we've got people getting into residency programs as a part of a quota versus actual talent, or getting into medical school by quotas instead of actual talent. And so over the years, what we've seen is this kind of shifting of people. Even back when I went to medical school, there was a girl in my class who fit a certain characteristic pattern. And the Creighton University, where I went, I think they were trying to be a little bit woke 35 years ago. The problem was this girl, one of the benefits that she got over the rest of us was she got to go a month early to start her first year of medical school. And she got another month of anatomy classes, which got her an A. And I will be freely admit this, I got a B- in anatomy and physiology. But I didn't get that opportunity to get that free class, and that would have been nice. She also had a scholarship that I was not privy to, and her parents were both doctors, and she was driving 35 years ago an Audi. And I mean, she was pretty well to do. She had more money than probably all of us. So I just think these programs sometimes don't always do what they're supposed to do, and they end up getting bastardized in the long run. So what's happening to residents is that there's been law after law after law that has been introduced to try and protect them so that they don't have to work miserable hours and, blah, blah. The thing is, that's when you learn. You learn when you put in the hours. There has never been a study that shows this concept that doctors who are worked harder make more mistakes. Actually, I think if anything, it's the other way around. When you work more and you put in more hours, you're less likely to make a mistake, especially surgery and things like that. And I'm sorry, I want the doctor that's operating on me to be damn good. I want them to be the person who has the experience. I could care less if they're DEI or if they're, you know, gender specific or whatever they are. I want the best person. I don't necessarily even need them to have a good bedside manner. It'd be nice and it would be a bonus, but I don't necessarily need to have that. So at the beginning, I talked about why women are being gaslighted. And I have to say that I think part of it is that a lot of doctors, like I've said, when they don't want to order labs, it's because they don't know what to do. It's because they didn't have the training to show them what to do in this scenario. So they just kind of blow it off. And when you hear things like, we don't test labs, their hormones are fluctuating all the time. Why would I do that? All that stuff is just complete garbage. And it's lazy medicine. So I wanted to bring up these little discrepancies in the training process because I think that's why women are getting gaslighted. Now, that's not everybody, it's not across the board, but you know what I'm talking about in the sense that when you lower the standards, then you have to keep lowering the things after the standards so that these people that you've lowered the standards for can fit in. Then there is a push that you should see a doctor that's the same gender or the same race, which is also ridiculous. That's racist and sexist on its face. And it doesn't necessarily convey that you are a good doctor just because you're a man or a woman, or, and in my profession of GYN, where I'm a man, I'm a minority now in that field. And it's interesting to see what that feels like, because women have been feeling this for centuries because they've always been kind of dissed by the working class community. So what I'd like to do is just remind everybody, be persistent. If they don't want to check your labs, that's okay. You're not going to convince anybody to do something they don't want to do, but you can walk away. You can find another provider that will help you. So keep that in mind. Check out thehormoneproject.com. You can find me on Instagram, Shawn Tassone, MD. YouTube, same name, same number. I also have, again, the book, The Hormone Balance Bible. If you're ever wanting to read anything about hormonal management, you should get that book off of Amazon. I hope you all have a good day. I hope your weekend is amazing as well. Have a good one.